Welcome guys, my name's Tamara Keith and I'm a paediatrics trainee in London, and I know Ed from medical school, lucky me. This is the first of 3 neonatology podcasts, and this one is, they're all sort of around the prenatal and perinatal period. The first one that we're going to do is about the placenta, amniotic fluid and intrauterine growth restriction. So our learning objectives are going to be to understand the functions of the placenta, to know what oligohydramnios and polyhydramnios are and know the definitions and the causes, and to describe what intrauterine growth restriction is and the different types and their causes. So the placenta, as you may know, is a metabolically active organ. So it's not just a thing, it's actually an organ which has functions, and it's essential for a healthy pregnancy. It regulates the two-way transport between the mother and fetus and has a number of different functions. The placenta is a complicated organ, and the way it develops is very complicated, as you can see from this slide. So placentation, which is the development of the placenta, begins with implantation of the blastocyst. So this is after fertilization. The blastocyst goes into the uterus and implants into the decidua, which is like the lining of the uterus. So when it becomes in contact with the endometrium, the blastocyst becomes covered with an outer layer known as the syncytiotrophoblast and an inner layer known as the cytotrophoblast. The trophoblast then differentiates into 2 different layers, the villus and the extravillus. The extravillus layer is important to invade into the maternal tissues. The villus layer becomes in contact with the maternal blood and is involved in transport across the placenta. From 18 days after conception, placental blood vessels form by vasculogenesis, and this is essential and responsible for the nutrient and gas exchange. So the main 3 functions of the placenta are endocrine functions, exchange functions, and protective functions. Endocrine functions involve HCG, which sustains production of progesterone and estrogen by the corpus luteum. And HCG then goes into the urine, and this is what forms a positive pregnancy test. The other endocrine functions of the placenta are to produce progesterone and estrogen, essential for the ongoing of the pregnancy, and human placental lactogen, which prepares the breasts for lactation, otherwise known as breastfeeding. The exchange functions are simply that the placenta gives the fetus oxygen, nutrients and water from the mother and removes the waste products and carbon dioxide for the fetus. So you can think of the placenta as a bit like the fetus lungs, because the lungs are not active in the fetus. The protective functions of the placenta are that it stops the maternal and fetal blood coming into direct contact. So this is sometimes what people get confused of. They think that the mother's and baby's blood is actually mixing. It's in close proximity, but it actually does not mix. And the trophoblastic cells form a barrier between the mother and the fetus. And then the waste products and then the bits and bobs that the fetus wants, like oxygen and nutrients, then diffuse over this layer. And as I said before, the placenta is absolutely essential for a successful pregnancy and a healthy baby. So complications with the placenta can result in things like intrauterine growth restriction, which we are going to talk about later. So now we're going to talk about how we assess fetal growth. Obviously, if a fetus is small and not growing properly, we think that there's a problem. But how do we know that the fetus has a problem? So a lot of people used to think that just monitoring the size of the uterus, so is the woman's tummy growing, meant that the fetus was growing well. But actually the size of the uterus correlates poorly with fetal growth. And fetal growth and well-being are determined in a number of different ways. So first and foremost, obviously ultrasound, and we measure different things: the fetal biparietal diameter, the abdominal circumference, and the head to abdominal ratio. The head to abdominal ratio is one of the most important, as what we want is for the head and the abdomen of the fetus to be growing at the same rate. If the head is growing faster than the abdomen, this is a sign of asymmetrical intrauterine growth retardation, which we will talk about later. And obviously if both aren't growing properly, then it's a sign of more generalised growth retardation where the whole of the fetus is affected. Amniotic fluid volume is important to measure, and quite simply there can be too much or too little, and these are signs of various problems going on in the fetus and would need to be investigated further. Something that I'm always interested in as a neonatologist when I go down to deliveries is the fetal umbilical artery Doppler. So they measure the fetal umbilical artery, they measure the flow, and if it's absent or reversed, this means that there is poor placental function. And reverse is worse than absent flow. And this is associated with increased perinatal mortality and intrauterine growth restriction. So it basically is indicating that there is a problem with the placenta because the flow in the umbilical artery is poor. Now we're going to talk about oligohydramnios and polyhydramnios. So this is to do with amniotic fluid. Oligohydramnios is where there is too little amniotic fluid, and it's less than the 5th centile for gestation. So in paediatrics, we like plotting things on graphs and giving centiles. The 50th centile is bog standard average, and 5th centile is very low, and 95th centile is very high. So that's how we think of it. So less than the 5th centile is too little amniotic fluid. And we measure something called the amniotic fluid index by ultrasound, and measure it in 4 different areas, and then you from that get the amniotic fluid index. You can suspect oligohydramnios before you even do an ultrasound in different ways. Firstly, the lady may have a history of leaking of amniotic fluid, so premature prolonged rupture of membranes is PPROM. And this is simply that there's been a story of fluid leak from the vagina, which would be an indication that she may have leaked amniotic fluid. And obviously if you've lost some amniotic fluid, it's not going to be in the uterus and you're going to have oligohydramnios. The other clinical sign is when the fetal poles, so as in the head, the feet, the bottom, any part of the fetus that you can feel very obviously on examination and would feel obvious and hard, is an indication that there's not enough amniotic fluid. You can feel a baby when you examine a pregnant woman, but you shouldn't be able to feel it very, very easily. The causes of oligohydramnios are many and varied, the most serious of which is renal agenesis, so when there are no kidneys in the fetus. This is incompatible with life and is known as Potter's syndrome. So the fetus has no kidneys, is not producing urine, and so there is no amniotic fluid. And you may or may not be aware of that amniotic fluid is a mixture of different fluids, but is mainly the fetal urine. So it is mainly kidney and urological problems of the fetus which cause oligohydramnios. So you've got renal agenesis, multicystic kidneys, or any other urinary tract abnormality. So you could have a urinary tract abnormality causing bladder obstruction, which would result in low amounts of amniotic fluid. Intrauterine growth restriction and placental insufficiency is another cause. And NSAID, so ibuprofen, is highly contraindicated during pregnancy, as this has multiple effects on the fetus, but one of which is to reduce amniotic fluid. And as I discussed before, that the premature prolonged rupture of membranes, so loss of amniotic fluid, obviously reduces the amount. Polyhydramnios is excess amniotic fluid, so above the 95th centile for gestation, so way above average. And you would suspect this clinically in a lady who's got severe abdominal swelling. They feel uncomfortable. The abdominal size is out of proportion to the woman's gestation. So her tummy is a lot bigger than you would expect for her stage of pregnancy. The abdomen is tense and it's hard to feel the baby inside the tummy. The causes of this, one very common cause is diabetes. This can be insulin-dependent diabetes or gestational diabetes. And multiple causes that you can see on the page. So chorioangioma, AV fistula in the placenta, multiple gestation. So where you've got twins, you can get twin-to-twin transfusion. This can also cause polyhydramnios. You can have idiopathic causes, so that is that we don't know what the cause is. Esophageal atresia. So there's a block in the esophagus, and this stops the fetus from swallowing the amniotic fluid. And so as I was explaining before, that the amniotic fluid is the fetal urine, and when they swallow there's a continual cycle of production of amniotic fluid and then swallowing of the amniotic fluid. And if they cannot swallow the amniotic fluid, then there's going to be too much because they're still producing it. And that can occur in esophageal atresia and duodenal atresia, or in a neuromuscular condition preventing swallowing. Now we're going to go on to talk about intrauterine growth restriction. This is quite common in medical school paediatric exams, that they like talking about IUGR, the different types, the definition, and what the causes are. And this is because it's one of the most common complications that we see in paediatrics. As in, we see at deliveries, you are called down to see a baby which is too small, or it's come up on the ultrasound that the fetus is IUGR. So the definition of intrauterine growth restriction, which you may see in older books called intrauterine growth retardation, but we don't like that terminology anymore, so it's intrauterine growth restriction. The definition is when a baby has failed to reach its growth potential, or where there has been a decline in growth velocity. So both basically mean the same thing. So it is where a baby is growing at a certain rate and then that rate declines. So it hasn't reached the size it was initially expected to. IUGR can be symmetrical or asymmetrical. Symmetrical IUGR is when the head and weight are both reduced. So you have a small head and a small body, and this indicates an early pregnancy problem. This is the most severe type of IUGR. The causes include chromosomal abnormality, so trisomy 21, which is Down syndrome, is a cause of symmetrical IUGR. Congenital malformation. So again, this would be a cause early in pregnancy where there's a major problem with the fetus, and this causes early growth restriction. And intrauterine infection is another cause of symmetrical IUGR. So you can have CMV infection, rubella, and toxoplasmosis can all lead to symmetrical IUGR. Asymmetrical IUGR is when the weight is affected to a greater extent than the head. So what I mean by this is that the head keeps growing, but the abdomen does not grow at the same rate. So this is what we call head sparing. So the fetus has sort of gone into an emergency mode where the blood supply to the vital organs is spared, so the heart and the brain are spared and keep growing, but the blood supply to the abdomen, the gut, the liver, the kidneys is reduced, as this isn't thought as so important as the heart and the brain. So the head keeps growing and the body doesn't grow at the same rate. The causes of this are third trimester restriction, so later on in pregnancy than symmetrical IUGR. The causes are many and include maternal causes, which would be poor nutrition, chronic disease like kidney disease, substance misuse, so alcohol, drug misuse, and generally low socioeconomic status, because that is associated with poor nutrition, chronic disease and substance misuse. Placental insufficiency, so more a fetal cause, is also associated with this, so preeclampsia, hypertension, sickle cell disease and multiple gestation are all associated with asymmetrical IUGR. This is not as severe as symmetrical IUGR. So as I said before, a cause of asymmetrical IUGR is what we call uteroplacental insufficiency. So this is basically a poor placenta. It's failure of the extravillous trophoblastic invasion, and this results in high uteroplacental resistance and reduced uterine artery blood flow. So you may remember before I was explaining about uterine artery Dopplers. So if you have reduced or absent fetal umbilical artery flow, this is a sign of uteroplacental insufficiency. This I know all sounds very complicated, but what I'm trying to say is that a cause of asymmetrical IUGR is having a poor placenta, and the clinical sign on examination of a poor placenta is from an abnormal Doppler. So why do we worry about intrauterine growth restriction? We worry because these babies are very small and they're at risk of many complications. They're at risk of getting cold, so hypothermia, because they're small and they have reduced subcutaneous fat. They are at risk of hypoglycemia, and I've realised that we have spelt that wrong. So the list should be hypothermia, hypoglycemia and polycythemia. So hypothermia would be due to the reduced weight and subcutaneous fat. Hypoglycemia, because there is reduced glycogen stores. So these babies get low blood sugars because they haven't got as much glycogen to make the glucose. And they get polycythemic, so they get a raised hemoglobin, which can put you at risk of many things, and they have polycythemia because of chronic hypoxia. We have to do quite a lot of investigations when an IUGR baby is born. We need to first of all confirm the gestation, because are we sure that this is a growth restricted baby, or have we actually just got the gestation wrong? We need to do a karyotype on the baby if there's any dysmorphic or congenital features. So this is if there's an obvious abnormality on examination of the baby, we need to do the karyotype, which is sort of looking at the DNA of the baby. So is this an XY baby? Is this a YY baby? Is this an XX baby? Are there all sorts of funny things going on? So we need to know, is this a girl? Is this a boy? Is this intersex? Are there Down syndrome or other genetic abnormalities going on? So we need to screen for congenital infection. Has the mother had rubella during pregnancy? We need to ensure that there are early, regular and frequent feeds, and we need to monitor the temperature and sugar of the baby, because these babies get hypothermia and low sugar. And last of all, we need to do a venous blood test to check the hematocrit. So this is to check for polycythemia. SGA is small for gestational age, and this does not necessarily mean the baby has IUGR, but they can have both. So small for gestational age is when the birth weight lies below the 10th centile for gestational age. So this baby may just be small but normal, or may have been expected to be born on the 50th centile, and in which case this is IUGR. So small for gestational age is not the same as IUGR, but it is a small baby who may or may not also have IUGR. Fetal macrosomia is a large fetus above the 90th centile. This is most commonly due to maternal diabetes, but could just be it's a large baby with large parents. And a common problem with this is shoulder dystocia. So they get stuck on the way out, the shoulders get stuck. It's an obstetric emergency and can result in clavicle fractures and increased rate of Erb's palsy. Here are a number of definitions. I hate learning definitions, but medical school exams and further postgraduate exams do like you to know these definitions. There's no particular easy way of knowing them, and I'm afraid you just have to sit down and learn them. So the stillbirth rate is the number of babies born without signs of life after 24 weeks of gestation per 1,000 total births. So stillbirth is when you are born after 24 weeks of gestation without signs of life. And so the stillbirth rate is the number of stillbirths per 1,000 total births. Perinatal mortality is the number of stillbirths and deaths within 7 days per 1,000 total births. Early neonatal mortality is the number of deaths within the first 7 days of postnatal life per 1,000 live births. Late neonatal mortality is the number of deaths between 8 to 28 completed days of postnatal life per 1,000 live births. Neonatal mortality is the number of deaths up to 28 days of postnatal life per 1,000 live births. Post-neonatal mortality is the number of deaths from 28 days to 1 year per 1,000 live births. And those two last definitions differentiate in the sense that neonatal is the first 28 days of life. Infant mortality is the number of deaths in the first year per 1,000 live births. So in summary, we've covered a lot there. The placenta has endocrine, exchange and protective functions. Oligohydramnios is too little amniotic fluid and can be caused, for example, with kidney problems like Potter's syndrome where there's renal agenesis. Polyhydramnios, where there is too much amniotic fluid, which is commonly caused by maternal diabetes. Intrauterine growth restriction can be symmetrical or asymmetrical. Symmetrical being where both the head and the weight are low, and asymmetrical being where there is head sparing. Macrosomia is a large baby, the commonest cause of which is diabetes. So that's the end of my first neonatal podcast, and I hope that's been helpful for you, and I will shortly go on and do another one. Thank you very much.